Everyone. Welcome to the second run of the second series of webinars on the HSG protocols run by the College of Family Physicians. My name is Suraj Kumar. I'll be your moderator for this series. We have 5 webinars covering the 6 protocols that are part of the second series. Today will be the second one, which will be on chronic kidney disease. So we will run these webinars every Wednesday night at about the same time, and we will follow the same format as previously. First of all, there will be a presentation by one of our council members. Today it will be Dr. Sharon Chen. That will be followed by a Q&A session where we will be supported by our resource persons from MOH, AIC, and the protocol subgroup. And there will be MCQs after, which will be released in 2 batches. The first batch will be released after the 3rd protocol. It'll be after next week. And do attempt the MCQs because you'll get an extra CME point. And for those of you who can't attend, or your friends who can't attend the webinars, don't worry, the recordings of the webinars will be placed on the college website for everyone to access in their own convenience. So without much further ado, I think we start off today's session on CKD, and I'd like to introduce Dr. Sharon Chen. She is a private GP, private family physician, and a college council member. So without much further ado, Sharon, over to you.
Hi, very good evening, everybody. I'm going to share my screen now. Let me know if there are issues accessing the slides. You should be able to see it now, but if you can't, please holler, and please let me know if you can't hear me or if I drop off at any point in time. First of all, very happy new year. It's 2025, and we have launched a whole new series of care protocols this year. I hope that all of us are getting used to, onboarding our enrollees, as well as some of them are even coming back for their second consults already, right? So as Suraj mentioned earlier, I'm one of the council members, and I'm also a private GP whose clinic is in the Heartlands. As we go through the CKD care protocol today, I'll be taking you through a case study of one of my patients, so that we can go through the various segments of the care protocol. Please bear in mind that as I share, in the background supporting me, as Suraj mentioned, are members from AIC, from MOH, from the care protocol team, the ACE clinical guidance side as well. So don't wait until the end to ask your questions. Please feel free to type them on the chat, and I can assure you that they are all very learned and they will respond very quickly to all your queries. These are the references for today's webinar. If you forget everything, if you're not sure where to get the information, just type into Google primary care pages, Healthier SG, care protocols, and everything will be there. All right. So don't panic if you cannot remember anything, if you are not sure how to submit your data. This website lists all the care protocols as well as various other resources, such as information on schemes and programs relating to HSG. So it's good to explore this website, not just for care protocols, but anything.
Aaron, sorry to interrupt. I think are you sharing your slides? Because
am I?
Yeah, you got a screen share again.
Can I screen share again? Sure.
Yeah, because we can't see your slides. Yeah.
Okay, let me just go.
Okay, got it. Go into the
Okay,
good.
so this is the primary care page website. So even if you don't see my slides for tonight and you just hear me talking, if you just follow along with the primary care page, I assure you that everything will be covered as well. All right. A lot of the care protocol has been referenced from actually the ACE clinical guidance, CKD, on early detection that was released in 2022, as well as the one on delaying progression and reducing cardiovascular complications released in 2023. So please do read through them. It is a very, very good source of information on CKD. And for this webinar, I also like to credit the nephrologist friends from our Singapore Society of Nephrology. Every year, they take the time to organize a renal masterclass for primary care physicians. And I'm sure some of us here attended last year's talk, and I've adapted some of the slides as well as the case study from the session that was held in July last year, as I was the primary care representative. So I do need to credit them as well. So without further ado, Mr. Daniel is my patient that came to see me for the first time last year. As we all know, we have lots of patients and they transfer clinics for various reasons. And in Mr. Daniel's case, he actually moved house. He was with his previous GP for quite a number of years. And since I was on his company panel and I was just, a block away from his new place, he decided to explore my clinic. So he is a 42-year-old male, Eurasian. His BMI is on the high side, is 33.9. He is in the obese range. His blood pressure is 134/86. And his previous GP has diagnosed him with the following medical conditions: type 2 diabetes, hypertension, hyperlipidemia, fatty liver, and gout. And he has been on the following medications for the last couple of years: metformin 500 mg twice daily, atorvastatin 10 mg once daily, allopurinol 100 mg daily, telmisartan 40 mg once daily, and amlodipine 5 mg once daily. So fortunately, he brought along the previous lab results done at his clinic. And I've uploaded the ones that are applicable to tonight's CKD session. So you can see the renal panel there. The eGFR is 115. The urine ACR is at 29.1 mg per millimoles, and his latest HbA1c is 6.9%. So the question that I had in mind before even speaking to Mr. Daniel was, does he have CKD? Does he have chronic kidney disease? Now, bearing in mind, this is my first session with, my first consult with Mr. Daniel. He is fairly young. He's only in his early 40s, but he already has multiple comorbids. He is already on multiple medications. So I was wondering if I should add one more label of CKD onto his already extensive list of diagnoses. So let's see what the CKD care protocol says. As we all know, the burden of kidney disease is increasing, not just in Singapore, but around the world. And CKD, unfortunately, doesn't occur as an isolated disease, but CKD does confer an increased risk of cardiovascular events, especially in the later stages. Causes pertinent to us in the primary care would be commonly diabetes as well as hypertension. Of course, CKD can be caused by cystic disease, glomerulonephritis, and as well as other structural causes, but this is out of the scope of the HSG CKD care protocol. So we won't be touching so much on that today. Then, following on to the clinical approach to CKD, as I was thinking whether I should make this diagnosis on Mr. Daniel, I was reading through the care protocol, and it says that the diagnosis of CKD can be made if any one of the following is present for 3 or more months. Firstly, if the estimated GFR is less than 60 mils per minute. Secondly, if the urine ACR is more than 3 mg per millimoles or more than 30 mg per grams. Thirdly, if there are other markers of kidney damage, including structural abnormalities on imaging studies. If we feel that an ultrasound of the kidneys would be needed, we can order that as well. And also we know that in primary care, we tend to do a lot of health screenings. And if we pick up hematuria, pyuria, proteinuria, I think this should prompt further investigations if we are concerned about serious etiologies too. So looking back again at Mr. Daniel's labs, his eGFR is more than 90 at 115, so that is normal. But his urine ACR in mg per millimoles is is high at 29.1, which is more than 3 mg per millimoles. So indeed, there is a very high likelihood that Mr. Daniel does have CKD, right, at this stage. In addition, if I were to refer back to the ACE guidelines on detection of CKD, early disease, he does have diabetes, he does have hypertension, he is obese, he likely has metabolic syndrome. I would like to find out more about his family history, such as if he has cystic disease, but definitely he is known to have gout, and he may or may not have had recent flare-ups requiring lots of analgesia, and he is a smoker. So looking at the list of risk factors, Mr. Daniel has a very, very high likelihood of having CKD now. If I were to make the diagnosis of CKD on my patient at this point in time, then I would need to proceed to then stage his CKD, right? So if we were to refer back to the ACE clinical guidance on chronic kidney disease, even though his eGFR is normal at 115, which is more than 90, his urine ACR is moderately increased, and urine ACR is to be included as another component of CKD staging, not only because it is a marker of kidney damage severity, but because it is also associated with the progression of kidney disease. So combining the GFR and urine ACR, Mr. Daniel might have a moderately increased risk of CKD. But as we all know, I don't think it is wise to label him as having chronic kidney disease based on a one-off lab test. And therefore, I chose to repeat his laboratory tests 3 months after the initial tests were done. Unfortunately for him, even though his GFR remained high at more than 90, his urine ACR increased from 29.1 to 50.4. Some other practical questions that I did ask Mr. Daniel when he first came to see me was whether he was having any symptoms of urinary tract infection, or whether he was having vomiting, diarrhea, abdominal pain during the time that he took the first lab test. Also, he might have had, a bout of heavy exercise prior to doing the urine collection. So I wanted to ensure that for the second test, 3 months later, he was not sick, he was well, and that he could collect a random urine sample. Instead of collecting a random urine sample, that he collect an early morning urine sample instead, which he did really well. But still, the urine ACR was shown to be elevated. So then in this case, he now has a high risk of progression of his CKD as per the chart indicated. From yellow, it is now at orange, and he is at high risk. So then we can now, unfortunately, confirm that he has CKD, and we can now add on the additional label of CKD onto Mr. Daniel. But be assured that we don't have to refer him to the nephrologist immediately. CKD stages 1 to 3A, early CKD can be managed in primary care, and we are confident that as primary care physicians, as family doctors, we can manage them. And how do we manage them? First, I think we need to have this conversation. So I really did have this conversation with Mr. Daniel. I had to sit him down. I had to tell him that he does have chronic kidney disease. It is likely due to his diabetes. It is likely due to his hypertension. And he does have several risk factors contributing to his CKD, including things like his obesity, including things like his smoking status. Sometimes it is very difficult to cover all the education all in one setting. So if we had attended the gout webinar last week, Sister Marian also shared that the PCN nurses can be roped in to assist in patient counseling and in patient education. I think as family physicians, we need to understand that we are not the sole primary care, we are not the sole healthcare provider for an individual. So if we need to really ask our friends for help, ask our colleagues for help, I think we shouldn't shy away from doing so. Secondly, we can optimize the management of his modifiable causes and risk factors. He does have high blood pressure, he does have dyslipidemia, and he does have diabetes. So if we're not sure how to manage all these, don't worry, the care protocols are also on the primary care page's website. So the specific targets are listed there. If we don't know, please kindly refer to them as well. Lifestyle management is very important. Weight management, he has a BMI of 33.9. Sometimes it is very easy for us to just tell him, yeah, Mr. Daniel, you need to exercise more, you need to lose weight and everything will be okay. But really, have we tried losing weight ourselves? I think we have all tried losing weight and it is not easy, right? So sometimes we need to assure them that we are going to journey with them on this weight loss management, and it can help indeed with their kidney function too. He is a smoker. I would like to highlight that the ACE clinical guidelines on smoking cessation will be released soon in the next couple of months. So if we need to update ourselves on some of the techniques of how to get people to stop smoking, please look out for the ACG that will be released soon as well. Of course, we can also optimize management and initiate the necessary workup for complications associated with CKD, such as anemia, high K, high phosphate, fluid retention, as well as pericarditis. And we should be initiating or optimizing our patients on the best medical therapy to help with their kidney health. And how do we do that? Referring back again to the care protocol as well as to the ACGs, we all should know by now that ACE inhibitors as well as ARBs are the first-line antihypertensives that we should start or titrate to maximum doses in CKD patients with diabetes or CKD patients with the presence of albuminuria. I think by now we know that many guidelines, many studies show that ACE inhibitors and ARBs indeed improve kidney outcomes regardless of diabetic status. And although they are both very good, we should only choose one class of medicines. We should try to avoid combining both because of the risk of hyperkalemia. I particularly like this chart in the ACG because it summarizes the initial doses that we can start our patients on, as well as the maximum doses that we can titrate to. So we don't really have to remember everything. We can just pull it up, search the ACE clinical guidance, and the chart will be there as well. So back to Mr. Daniel. When I saw him again in 3 months with his latest round of blood tests, I confirmed that he has CKD. And now I need to ask myself, how do I manage the increase in the urine ACR from 29.1 to 50.4? Should I increase the telmisartan to 80 mg daily? Should I add on an SGLT2 inhibitor? Should I start a GLP-1 receptor agonist? Or should I just refer to the nephrologist? So with the help of the care protocols, with the help of the ACGs, I decided to increase the telmisartan to 80 mg daily because if we refer back to the chart here, I have not maxed out the dose of telmisartan. He was initially on 40, and hence I decided to increase his dose to 80 mg daily. The second class of medications that we commonly use, and we've heard a lot about this in the last, say, 3 to 5 years, are the SGLT2 inhibitors. Indeed, initiation of SGLT2 inhibitors should be considered in patients with CKD, especially if their GFR is more than 20 mL per minute. With persistent albuminuria as an adjunct to standard therapy to reduce the risk of sustained GFR decline, end-stage renal failure, and cardiovascular death. So please bear in mind that 20 ml per minute is the cutoff for empagliflozin. For dapagliflozin, it is 25 ml per minute. And for canagliflozin, it is 30 ml per minute. So we also need to assure our non-diabetic patients that there have been many studies that were done, and that and especially in the DAPA-CKD trial, there have been no major hypoglycemic events, even if SGLT2 inhibitors, traditionally known as a diabetic medicine, and it is safe to use for non-DM patients as well. This can be continued until initiation of dialysis. Although at eGFR of less than 40 mL per minute, if we are really trying to lower the HbA1c, we might want to consider another glucose lowering agent, because the efficacy of SGLT2s are attenuated. However, we still should put our patients on the SGLT2 inhibitors, even if their eGFR is less than 45 mL per minute, because SGLT2's inhibitors continue to have renal protective and cardioprotective effects. So thankfully, Mr. Daniel is very compliant, and he has decided that we should that he is willing to continue to work with me on his kidney health. So 6 months from the time that I first saw him, I repeated yet another battery of tests, especially after adjusting his dose of ARBs. At this point in time, he was already on the max dose of an ARB. However, his urine ACR, although less than before, is still elevated and is still normal. So I was thinking to myself, what should I do for him now? Would I then reassure him that since his urine ACR is now, better than before, in fact, they are maybe normal, I can just repeat his medications and see how it goes at the same dosages? Should I then add on an ACE inhibitor in addition to his ARB? Should I add on an SGLT2 inhibitor such as empagliflozin? Or maybe just repeat the investigations in 3 months? Or should I start getting a little bit panicky and, refer him to the renal physician? So I did have this discussion with Mr. Daniel, and again, I asked him, going back to basics, asked him again, was he having a UTI or GE episode when we did the blood test? Did he have take any NSAIDs from another doctor for his gout flare-ups or for any musculoskeletal pain? Is he okay if we adjust the medications for him? Is he having side effects? Is he actually taking the medications that have been prescribed to him? So in Mr. Daniel's case, he says that he has been well, he's been taking the medications as prescribed, and he admits that he is young and he would like to prioritize his kidney health. And so we decided to jointly start him on empagliflozin 10 mg once daily. So this looks like a very busy slide, but it's actually very nicely put together by the care protocol team. And it is a summary of the approach to using ARBs and SGLT2s. When to start, what doses to start, what happens if we encounter difficulties like hyperkalemia, or if the patients have side effects. So I will not go through everything on this slide, but what I did personally in my practice was to print this out and file it right beside my table, and I refer to it when I encounter difficulties. In fact, if you don't want to print it out, I'm old school and I print out. If you don't want to print it out, you can just Google it, go to the care protocol website on the primary care pages, the website, and then it's there as well. So I do encourage you to really follow the flow chart, and it is very nicely done up, it's very elegantly done up. So do refer to it because it is a very good summary of the approach to using ACE inhibitors, ARBs, as well as SGLT2 inhibitors. Now that we've talked about the medications that we should start our patients on to optimize their kidney health, we need to bear in mind that a lot of common medications that we use on a daily basis may worsen their kidney health. So These include things like antimicrobials, medicines used for cardiovascular diseases, for diabetic medications, pain medications, as well as other things like colchicine. So if we are finding difficulty in bringing down their urine ACR, or if their eGFR keeps going up, for example, if their eGFR keeps going down, for example, I think it is good that we should review their medications, not just the ones prescribed by us, but prescribed by other doctors, for example, their specialists as well, to see if they're concurrently, on all these medicines that might worsen their kidney health. So this chart can be found again in the ACE clinical guidelines. If you are not sure, do refer to it. Then we need to remember that we are not alone in this. If despite all that we have tried, we have optimized their ACE inhibitor doses or their ARBs to maximally tolerated doses, if we have started them on SGLT2 inhibitors, but if our patient's kidney function continues to deteriorate or progresses rapidly, if they do have complications of CKD, I think that our renal colleagues would be more than happy to share their care of the patient with us, okay? So if we need to refer, we should refer on. In the care protocol, there are recommended care components on how we should manage our patients with CKD. This includes things like what we should titrate their BP to, or how often we should measure their blood pressure, how often we should do their smoking assessment, what vaccinations we should give them. In particular, for kidney function, how often we need to monitor their kidney function. But remember that these are just recommended care components, okay? Every patient is different, so we should target our therapy and management to the patient that is sitting right in front of us right now. And remember that as a family physician, we do have a longitudinal relationship with our patients. They see us at least 3, 4, 5 times a year. They don't not only see us for chronic care, but sometimes they see us for acute care. They see us for preventive care as well. So for example, we don't have to go through every single care component at one sitting. So if they are coming like Mr. Daniel, for example, if he came towards the end of the year because he was going traveling, right? So I took the opportunity to talk to him about the whether he had his vaccinations done for influenza, whether he has his vaccinations done for the pneumococcal 23, and whether he had the updated COVID vaccinations done as well. And every now and then, when he comes to see me to take, a medical leave for his URTI, I would again ask him if he's ready to quit smoking, and if he's ready to quit smoking, how I can journey with him on this. So remember that although there are so many care components that is recommended on the care protocol, we don't have to cover every single item in one sitting. I think it's very overwhelming for us, and definitely very overwhelming for our patients. So use the advantage that we are the patient's family physician, and we can talk to them bit by bit, and we can engage them over a course of a few months to a few years. Data submission, there is a list on the primary care page's website, but for kidney, if we are going to focus on CKD, please, of course, it must be a diagnosed, it must be a known CKD, right? So we do need to submit the urine ACR or urine PCR. We do need to submit the data on the eGFR or serum creatinine. And if Mr. Daniel is a Singaporean, he is a Singaporean, currently he is on a company insurance, but I also encouraged him to apply for his CHAS card because and enroll at my clinic, because CHAS, PG, MG card holders who are Healthier SG enrollees can also opt to use the Healthier SG chronic tier at my clinic as well for his his medications and investigations. So learning points. The diagnosis of CKD is not just based on eGFR, but also the degree of albuminuria. Remember that, they may not see it now, but if we talk about dialysis, usually a lot of patients are quite concerned, right? They don't want to go on dialysis because, they've either had relatives or they know of people on dialysis and they think that it is, it's a big no-no for them. So I think we can use that to engage them, to tell them that we can work together to protect their kidney health, to prevent dialysis in future. And of course, at-risk patients, we do need to monitor their kidney function, including urine ACR. Remember that our treatment strategies is not just medications that we should start them on or medications that we should avoid, but non-pharmacological options as well, such as weight reduction, such as smoking cessation. So we have many, many tools as primary care physicians. We may be sitting alone in our clinics, attending to our patients, but we have references that we can look to search up, such as once again, the Healthier SG care pages. Once again, the ACE clinical guidance on CKD. And remember that if you're not part of a PCN yet, maybe we should join a PCN, because when we're on a PCN, we can ask our colleagues for help. We have an AIC rep there that we can ask for help as well. And bear in mind that we can also engage our PCN nurses as well as our allied health providers for help. So we are not alone in this. We can work together to help with our patients on their kidney health. I'll leave the rest of the time for Q&A. Please feel free to ask anything. As I mentioned,